From BCHS Community Health Services, I've all met you already and talked a little bit about who I am. So, I'm Peter Strange from BCHS Community Health Services. I'm a men's health nurse practitioner, so I've been doing that for about 15 years. So all things men's health. Probably what I may offer, if anything, today is about the practical aspects of talking with men, and obviously we're talking about men with disability and sexual health today. And that's what I've learnt comes from the ground up. I've had the opportunity to speak to lots of men in lots of private situations, and I'll talk a little bit about men and men's health and where that fits in, and then add in I guess the barriers and the complications of a male with disability, and then add in another layer with disability and sexual health. So obviously that puts three layers with regards to that. So I'm nurse practitioner, community health promotion, basically work health promotion. I run a men's health clinic and a sexual health clinic sort of combined together. The design of this is a really good design as a model of practice. So I actually go out to see men, do talks, go out to TAFE, to the colleges, go around the schools to do sexual health talks, go out in houseboats and talk in workplaces and talk in farmyards and all sorts of places. So they actually, that works really quite well when we're talking to men, because they actually get to see me, either good, they can either like or dislike me, and therefore that's the engagement process of men. Men are much harder to engage in health, particularly preventative health, than they are generally than women. That's a statement that I'm happy for you to dispute, but that's probably accepted. So the engagement process of men is vital. If you just present a clinic and it's a 5 or 10 minute consultation, and the guys have to get off work and they have to do that, and particularly if they have to talk about something that's embarrassing or personal, then you ain't just going to get them there. So going out and meeting them in those places, and then saying, I'm the guy that you're going to meet, and giving them a long consultation is the way we've designed it. So they have a 45-minute consultation, doesn't cost them anything. They will actually meet me, is a good process, and we go out to them and then engage with them, and then hopefully that we run clinics of an evening, so they use the excuse I'm working or doing whatever. So all of those things are features that we've designed into men and men's health, and we've asked the men and we've surveyed them a long time ago about why they don't engage in preventative health and education and those sorts of things. So that's really important. So that's basically what we're still running, and we haven't really changed it. I'm probably doing a little bit more clinical work, and I'm working in the areas of mental health, sexual health, general men's health, and drug and alcohol, and then adding in disability and people, with regards to that. So I've entitled this, and I've used this PowerPoint before, because when we're talking about it, I'm fortunate enough to work with Yvette and Beck and Kat, as she likes to be called, the three previous people, and I work in that program, which is Respectful Relationships. Magnificent program, peer educated. So if we can run a program, there were 3 4-hour sessions included in that program, and if I've worked with all 3, and they actually present the program, and we're in there to help them run the program and the logistics. And if they can present most of it, then it's done from peer to peer. You're talking about trust, you're talking about engagement, you're talking about people with disability talking to people with disability. It's fantastic, and those three ladies are absolutely fabulous, and I worked with them quite a few times. So that program is still out there to be run, and can be, and we've run that on several occasions. So.
Have you got any male peer educators?
We had one, and then he pulled out. So he was training, and then he pulled out. So we haven't. So we can, and when we see how many people turn up, once again, there's a deficiency in males. Yeah. Yet when you're going to be talking about sexual concerns and harassments and police and whatever, and guess who's the numbers are up the other way. So there's a a deficit in one and an excess in the other, and we acknowledge that, but we keep on trying to try and do that. But what they were actually saying, and that's why we wrote that note down there before, is that we're talking about disability, but these people have the ability for most part to be able to learn, and I much think about that. Just going to go a little bit ahead, and I promised I wouldn't talk about sort of sexual assault and too much, but there is, I guess, a taint recently, and we're talking about pathologising men, and we need to talk about that because there's certainly statistical, very evident sexual assault and that sort of thing is I don't know what percentage, doesn't really matter, but we're talking about, and I'm starting to see that come through the media, that men are bad, men are generally good with regards to this, and men, with disability are often getting reported for doing inappropriate things, but we mustn't pathologise. We must sort of become positive about it, how we can change and how we can educate and get that relationship coming together. And I'm just a little bit aware of that, but I totally agree with the statistics and where the focus needs to be. But from the men's point of view, and that's what I'm here to do, and I see that, and of course I speak to guys in confidentiality about, and some of them do lack education. What am I doing wrong? Why do I get into trouble? What's the appropriate with that relationship, and how am I talking that's inappropriate? There needs to be education, and you're right about the stuff that if they try and learn through Google and all that, then they're going to get that bad. So they do have the ability to learn if we can provide the services and the education and the engagement process. And I'll say engagement for men. If we can engage, they're actually pretty good once they decide they want to engage in education and information like that. But that's by far the hardest bit. So you can put on a program and no one will turn up, and that's quite common. So helping men with intellectual disability to understand, enjoy and respect what comes naturally, and that's what these girls said, and that's what they often say. They have all these sexual feelings, and they the same as us, and they have all these desires, and the relationship and love and all those things are there. And we've often heard like parents and people sort of say, well, don't go there, we don't want you to have sex, we don't want you to have that relationship, don't go out, because it's difficult and it's more complicated. Explain it to you and understanding that, and respectful relationships is about saying, no, that's not right. And this program was about saying that we can't flatten all those feelings. They're out there, and it's about creating the understanding for that, and obviously part of that is to do with men's health, is to encourage men to try and understand that and to go there if you like. So so exactly what that sort of said, intellectual disability, to understand, enjoy and respect what comes naturally, and it still comes naturally. I like pictures. So when I'm generally talking about men's health, I think there is a difference, and it's up for debate, but there is a difference between how men see themselves and how women see themselves. And of course, there's all sorts of different sexuality. It's not always, black and white, but this is what we sort of see. And I guess this is sort of saying men may see themselves in a different light. I don't want to change men from being men, and I don't want them to change their feelings just about their health and how they're respected in the community and how their relationship's going. So those changes that need to be necessary, whether it be education or whether it be understanding of their partners and their family and their relationship, is probably paramount as far as that's concerned. But a lot of guys will get defensive about things with regards to that. So a lot of the clients that I see, I started off probably quite a few years ago, and people would sort of say, can you see this client who's a male, who's got a disability and can he have some sexual education, and he's got some sexual health concerns. A lot of them start with, they got in trouble with the police, and they've presented there, and then the people say that whether they might be in the houses, or they may be in the schools, or they may be parents, whatever. Well, what are we going to do about this? And then we'll find. Oh, Peter, can you talk to these people? And it started off, oh no, I can't. I haven't really got any experience. No one else is doing it. Wasn't in Bendigo, so I'll start to do this, and I'll start to learn through family planning, some programs, and going down to those processes, putting it together, and working with people that work with disability, and designing sort of programs that hopefully helped was really important. So taking those three things into account was important. Men need a little bit of guidance. As you see, I love pictures, so but I use protection. So there's a lot of wonderful things that there's a series of these pictures which was done through WorkSafe, which is sort of saying men, and I think men with disability also have that that ability to take chances and to not consider everything. So I think they need a little guidance, but they need to still be treated, with regards to them being male and with regards to their ability or disability is important. So I think this is what I want to talk about mainly, identifying the barriers and how I've approached it. I'm not saying it's perfect, but taking into account what happens. So they may present to me for education, and I'll get a referral, or somehow that'll sort of happen. And it might be an instance where I've had someone that was reported in the MAL for sexual abuse, and someone else reported them, and the police came down, and they had to do the right thing, and they had to talk to this person, and then they'll want some education about what's going on, and after an engagement process, which may take 2 or 3 consults to get to know the person, is really, really important. And the first consultation, the first chat I have, very rarely gets anywhere near the sexual health or those sorts of things. It's about trying to understand their communication, which is really important, which I'll talk about in a minute, and then maybe the second approach is about how they feel, and then what went wrong. And I talk about this incident because this person was really quite happy and was very loving, and went up to someone that they saw, and they gave them a cuddle, which he always does, which, a male giving a female cuddle that they didn't really know, and then he was reported for touching her on the breast, and it was actually the logo that he was interested in, and he was fascinated with that. And then after about the 3rd or 4th or 5th session, that was described about what it was, and it was reported by someone else watching that, which was fair enough, and all good and all, whatever. And it's about educating and what to do and what not to go. So there's a lot of just listening and learning and finding, and quite an honest person, and that was sorted out. But then it's about appropriate behaviour too, and what you can and can't do, and what you can and can't do in public, and their understanding sometimes it's quite difficult, because what they see is they're just doing a really nice thing and they're just being happy and cuddling and being fun, and they've got themselves in trouble. Not always the case. So things like that are really important, and that's how I've sort of designed the program. With people with disability, I've often found that actually when I talk in schools about sexual health, and when I talk with people with disability in houses, I actually ask, very important, and I learnt the hard way, that those people that care for them, the carers, need to come along and at least hand over that communication. What level of communication, how do we get that together? And I invite them to come into the consultation at start, even if it happens to be male, female, and often the female carers will think, I shouldn't be here because you're going to talk about boys' bits. But what I'm sort of saying is that I need to have that communication, and if they just presented or plonked there, then we get nowhere, okay? And I haven't got any trust, and I haven't got any communication skills as far as that's. So that was the first thing I learned, and I did a couple of those without that, and it was pretty much a disaster. So having that handover is really important, and getting that information as far as that's concerned. Then, as I say, having long consultations is really important with regard to men, and with regard to their disability. They'll often present maybe to their GP who's got 10 minutes. It's a waste of time, and then it becomes a very negative type thing. So learning trust may take quite a long time, and handing that trust over, and then we might start to get somewhere. So often people with disability are isolated. That's fairly commonsensical. They may not have had a lot of communication, they may not have had much talk with regards to that, and the guys are no different from that. I would say possibly males can be more isolated because their ability to have a chat and communicate and ask questions, particularly with regards to sexual health and mental health and relationships, is less likely. So providing that, breaking that isolation, we must encourage people in the community to go there and ask those questions and to do that. And to all the carers out there, I actually ask them to be brave. People ring me up, and there's all sorts of carers and people and nurses and sort of say, well, and teachers, we don't want to talk about sexuality, and we certainly don't want to talk about sexuality with people with disability because we don't know anything about it. No, go there, bring the subject up and broach it, and then find a referral place to go to if that's necessary, and hand those situations over as we go. So it's really important, but just sort of saying, well, we don't talk about that, creates what we've answered the question, which is going nowhere, and then of course you could get older and get into trouble or have that lack of understanding. So clinical environments, yeah, it's still a difficult area. It needs to be confidential. I still have a room which is hopefully a bit friendly, but where do we do that? Where do we talk about those? Has to be the appropriate place and the appropriate time. So obviously people get embarrassed, and we need to give them permission. I know in the program that we do with the peer educators, we give them permission to leave the room at any time. So anyone's in the program. It's a really important statement. If you're feeling embarrassed, if you're overwhelmed, and they may have been sexually assaulted or there may have been some really bad experiences, people are able to go out of their room and go out for half an hour, and if they feel like coming back they can. So giving them the freedom to sort of say, I'm dealing with an emotion, and responding to that is really important. So and telling them that at the start we found is important. So clinical environments are a hard one because you tend to end up like in a doctor's surgery, and it's not always the greatest. I'm fortunate enough to have got a room that I've made male friendly. So it's got football jumpers and all sorts of things I've tried to, and welcoming, so it's not all about that sort of thing. So making males feel that they're important, and once again not pathologising them too much, can be of help. Whether talking to another male is good or bad, that's open for discussion, but I've seen lots of female clinicians who are very, very capable of talking across all of those different areas. So the fear of the unexpected is a really big one, and trying to break that down beforehand. So that's probably half the reason why they don't come in here. It's if they've done something wrong, the fear is they're going to be sent to the police, or they're going to be told they can't do something, and those sorts of things. So that often has to be started by the carer, and males will feel that they are in trouble, basically, and often that's when the education starts, when they're in trouble. So it's not exactly preventative health, it's actually not preventative counselling. It's actually it seems to go to the next stage, and then has to come back, and then the education has to start after they've done that. So that's a bit men's healthy anyway, because that's what I see all the time outside disability. Is men present to casualty and to critical care, and they're in strife. They've got a cancer, they've got mental health, they've had a heart attack, they've had a stroke, they've done whatever. When was the last time you chatted to someone about that or got that attended to? Oh, I've never have done that. That's a men's health thing, which is my job to try and break down. Pretty big job. I don't think I've got enough years left in my life to do that, but we're trying to make a nudge in that direction. So trying to get them early and trying to have those services, where we say men can talk, and men, it's okay to say this is how you feel, and to do that is really important, and recognising that area. Confidentiality is really important to males as well as females, but I run a little clinic in TAFE with the apprentices, and I go around the classrooms and I say, hi, I'm Peter, you can come and see me. They call it the shed, not a clinic. They come from the schools, come from all around, Kyneton and whatever, and they come into the trade, and they can just book an appointment without knowing about it, and then I say, when I talk to them as a class, I guarantee confidentiality, absolutely. That means I can't tell your boss. That means I can't tell your mum and dad. That means I can't tell your teacher. We can't talk about that when you come in that little room, in that little shed, if you, as you call it, and that's really important. So the first thing that those men come in and see, particularly younger men, well, first thing I do, now Pete, you said you couldn't tell anyone. Right. So for them to gain trust, you've got a guarantee for that, for them to hand that information over, and particularly with regards to sexuality, it's also with regards to drug and alcohol use, you've got to make those statements that's a guaranteed thing. Obviously there's some provisos about danger and things with that, but it's just, that's my experience, how important that guarantee of confidentiality is and how important that engagement process is, and that they understand and reducing their fear. Yeah, reduced consultation time I've talked about, just no good, waste of time, probably negative if you're going to get a 5 or 10 minute consultation, and it's with all men just don't turn up and they just won't come back, and then you've just lost them on the first one. So it's probably better not doing it than having an environment or a place or a ability to have a chat for them to go there. And communication I've talked about, which is so important, and I have to learn that, and it's so varied and it's so different with people with disability, and I don't profess to be an expert, but I need to be handed that over. How am I going to communicate? What do we need to do? We were talking a little bit about, you know, people with disability that can't talk, intellectual disability, whatever, you know, and I've made some cards, you know, with thumbs up, thumbs down, and going from there, and you invent things as you go along, you learn. So the second consult is how are we going to do this, and those sorts of things are really important. And then we start to get on a little bit better and knowing the person. So that's my insight, because you've got three things. I'll go again, is that men are probably more difficult to engage. Men with disability probably are more difficult to engage, perhaps because of communication. And then putting the topic of sexuality into there is the third layer of difficulty. So preparing to have plenty of time, probably 3, 4, 5 consultation periods. I allow 45 minutes, maybe an hour. The concentration might be only 10 minutes. So you book the time, and then if it's 10 minutes and you're out of there and you've got one thing, or they've just sort of said g'day, and then maybe the next consultation or the third consultation might be you just start talking about, you know, how they're feeling, or what's going on with the sexuality, and start to unpeeling it down there. That's really difficult in terms of financing that, in terms of explaining to your boss what you're doing and why you're having these, and you're not getting it back, and then notes up. That's what's needed, that time thing. And if we don't do that, or we're too scared to do that, then we just run over the top of it. And if there's a problem that's happening, then it'll appear later on. We haven't really got to the bottom and solved that, and I think that sort of fits in. That's the most important points. Yeah, just some lovely relationships, and when you do have a little bit of success with the guys, and they get a bit of understanding, and when they say, I didn't know that, or I didn't understand that, and once you get to that point, then I think you've really achieved something that's very, very special. That's probably been a bit selfish, but it's very rewarding once you say, that sunk in, and that guy didn't have that concept before, and now that he's got that concept, is really important, and it's amazing what they don't get. So one of the things I've learned is for them, after I've tried to engage and then tried to educate, before, if there is a program or a timing on it, I try and get them to repeat on their own. So they've got to tell me what I've tried to teach them, otherwise you've missed the point. So they come back to me, and I'll present them with a problem at the end, or a situation, and I'll say, what would you do there and why would you do that? And once they can repeat that, even in a basic form, that they know what's right and wrong and what's good, then I think that's relative. And even then, you may need to revisit in 3 months and 6 months' time to reinforce that program. And that's sort of how I'm running the program at the moment. Having some success. There's people that are more specialised and better at it in those sort of areas than me. but think about all the problems with engagement, but also the problems with engaging men. And once again, I think getting them in the door, getting them into that room to have a chat, getting them to open up. The engagement part is 99% of the education to do that, and we need to start to do those sorts of things. So sometimes we just need to ask with regards to men's health and with regards to mental health and sexual health. This is outside the disability, but this is sort of male. When I started the Learn program, we found no males had erectile dysfunction as far as the world was concerned, and there wasn't many mental health problems. As I started my program, and they saw Peter Strange, and then they went and saw the GP after me when I had my LPLATs on as nurse practitioner designing a men's health clinic. And then one day the doctor saw 4 or 5 men. 1 month the doctor saw 4 or 5 men with erectile dysfunction that had seen me, that didn't talk about that but talked to the doctor about that. And I thought, what's wrong with Peter Strange? What am I doing wrong? I thought I was a nice guy, easy to talk to, and I went and saw the doctor, and the doctor said to me, I said, why are they talking to you and not talking to me? And the doctor says, I decided to ask him. You got a problem having an erection? Oh, as a matter of fact, yes I have. So engagement is also about with men, whereas perhaps women may talk about, I've got this problem or I'm concerned about this. It's about that. So 2 questions in the normal clinic that I run with regards to men's health is 1, how you're travelling, mate? That's a mental health question in a very basic form. And do you have problems having an erection, or do you do it? Sometimes you have to just ask that question for them to start that conversation. And then the consult might go on for an hour and a half because you can't stop them. But opening that up I think it's a sort of a male thing. So I don't know how I've gone for time, but that's
another 2 minutes.
Another 2 minutes. That's not bad for a bit of a guess. Yeah. Look. So, is there any sort of quick questions? I like pictures. I've been through all those, breaking the barriers. Basically, men with a disability have the ability to develop positive, respectful relationships with carers, peers, and health professionals. Form a support system orientated towards the needs of people with a disability, and I guess that's what I've found at the moment. And I just like that picture. I think blokes sort of have a bit inventive and a bit dangerous, and I often say that women support men in their health. So, yeah. So that's pretty much the information I wanted to try and get across today, and what I found out over the years. So. Any questions or in that area?
You talked about how they have a negative experience with services like police or health institutions by getting in trouble for things that have happened. Do you have any advice around overcoming those fears through like positive exposure, or what kind of things have you found helpful in helping people access those services in a positive way? Yeah,
I think you have to unpack it. So you go back and let's this is it. This is where you've got to, and now we've got to unpack that, and we've got to sort of say, what are your beliefs? And they'll often say, well, what do I do wrong? Which is, and it might be blatantly obvious, and then it's about unpacking that, and then starting the education. And then going about rights and and equality and all those sorts of things. If no one's taught them and they've never experienced it, and that's it, it's there. And I'm not backing men against women against sexual assault and doing the wrong thing. They are doing the wrong thing. 100% they can't do that. But has anyone, if they don't believe they're doing the wrong thing? There was a wonderful. We talk about porn, and you would have seen the educational session with regards to how young people learn about, it was the porn side. And there was a wonderful survey done, I think she's a lady in Warrnambool that's very expert and has done that sort of thing. They interviewed young men and they interviewed young ladies, and they sort of talked about having sex and rough sex and all those sorts of things. And they asked the guys, and they thought, and she would say, well, I didn't really like that. That was really quite, horrible, painful, with regards to sexuality. And the guy said, well, that's what I was meant to do. I thought that's what she liked. And it's this, so unpacking, if this person has done something wrong, or is you know, been strong, or done what, or spoken in the wrong way, or acted in the wrong way. If they haven't been educated, and then we've just missed them all the way along, then we need to give, particularly the males who are probably responsible for a lot of that, we need to give them that education. So, okay, we hear what you are, now we've got an opportunity to go back. How do you feel? What have you been taught? What are your thoughts? Who are you? And then, you know, what about the consideration of equality, and then reteaching them as far as that's concerned, and then going back over that to see that they've got that